For the opportunity to present at this meeting. A quick note of acknowledgement for Dr. Marcellet, who I've known for 20 years. When I started my career here 20 years ago at Case Western Reserve, I had the privilege of working with some terrific spine surgeons, Henry Bowman and Sandy Emery and Dr. Marcellet, and they all clearly had great interest not only in clinical care, but in education of residents and fellows, and that's something that I really saw firsthand. And so clearly, Dr. Marcellet has carried on that great interest with this presentation and program. So I would like to spend some time talking about a clinical interest of mine, which is degenerative myelopathy, and some of the basics about the evaluation and management. And then a few minutes towards the end, talking about a project of ours that we've done looking at really advanced myelopathy. So we'll talk a bit about the anatomy and some of the clinical and radiographic presentations, as well as our surgical strategies and the surgical approaches. But then more specifically, talk about three areas of interest, including the natural history of myelopathy, really, which to this date is still a little bit not completely understood. And then two particular areas of interest, the asymptomatic individuals who have spinal cord compression but no myelopathic features. And then on the other end of the spectrum, the most advanced involved patients with such severe myelopathy that they're non-ambulatory and some of the challenges that they pose. If you look at the spinal column, there should be plenty of room for the spinal cord in this healthy spinal cervical spine. The upper cervical spine is quite capacious. Typically, we don't see relevant cord compression there. It's in the lower cervical spine where it tends to be more clinically relevant. But if you compare the diameter of the spinal cord, which is quite uniform from top to bottom at about 10 or 11 millimeters, there really should be plenty of room for the spinal cord within a normal spinal canal. However, disease pathology, generally degenerative conditions, can lead to compression of the spinal cord in all dimensions. The majority of it occurs anteriorly with disc and osteophyte complexes, but posterior pathologic processes like ligamentum flavum and malalignment can lead to varying degrees of spinal cord compression. And so clinically relevant myelopathy can occur in a variety of different presentations. This patient has the typical multi-level degenerative change in the setting of congenital stenosis and can be quite myelopathic. This younger individual with a relatively normal canal but a very large disc herniation become equally myelopathic. And then other processes like this patient with a pathologic fracture from metastatic disease up at C3 and cord compression can present with features of myelopathy as well. So a broad definition for myelopathy would be the clinical syndrome of variable, and that's an important word, variable signs and symptoms due to extrinsic compression of the cord. And the effect of this spinal cord compression can lead to progressive loss of function, altered gait, and potentially, ultimately, in most severe cases, paralysis. In looking at the clinical presentation, there's no real one pathognomonic presentation feature, but rather it's a variable presentation of both signs and symptoms. And the symptom severity, interestingly, doesn't always reflect the degree of cord compression on imaging. And a big factor that we see commonly is that pain oftentimes is not a major feature of presentation. And so oftentimes patients will come with quite advanced clinical myelopathy, and you just scratch your head wondering, where have you been? And it's because pain may not be a big feature of their clinical makeup. And this is really in sharp contrast to patients with radiculopathy, where pain is a major feature and patients present with radiculopathy very early on. So delayed presentation is not uncommon. Early on, patients with myelopathy may experience loss of dexterity, which is mild, or some mild gait disturbance or balance issues. There can be superimposed radicular pain if they have both myelopathy and radiculopathy. And then later in the disease process, patients can really get into trouble with altered gait and falling, loss of bowel and bladder function. But again, pain may not be present substantially. The signs associated with it, again, can be quite variable and can be mild gait disturbance to profound loss of function and spasticity and weakness. And then certainly objectively, we see hyperreflexia or altered reflexes as a common presentation sign. The diagnosis could at times be challenging, and that's because pain is not a big feature and the progression can be relatively slow and it can kind of sneak up on individuals. And that's why it's very, very helpful to have input from spouses or family members that may see this progress that the patient is not aware of. And so we always insist that a patient member or a family member or spouse is present for the initial evaluation and then certainly the discussion of the treatment. Physical exam is crucial, as is advanced imaging. And we really have a low threshold for obtaining advanced imaging if there's any suspicion that a patient has spinal cord compression. And I think, as we all know, this can be a challenge in this day and age to get insurers to approve advanced imaging. But this is a scenario where it really is worth the time and effort. If you feel that your patient has myelopathic features that have not yet been diagnosed and you want to get advanced imaging, it is worth the time to do peer-to-peers and get on the phone to really get these imaging approved if you're the first one that is evaluating the patient and trying to establish that diagnosis. What are our surgical goals when we see a patient with myelopathy? And really the fact is the vast majority of patients with myelopathy, surgery is an option and oftentimes is the best option. So our number one goal is to decompress the spinal cord. This is extrinsic compression of the cord, and our goal is to decompress this. And this can be done both directly or indirectly, but we're trying to do it in a fashion that is safest for the patient and limits surgical morbidity and potentially mortality. If a patient has associated malalignment of the spine or instability of the spinal column, that's foremost as one of our goals as well. How do we formulate a surgical strategy? Well, we want to know where the pathology is. Is it primarily anterior? Is it posterior? What is the alignment of the spine? If the patient's spinal column is preserved without instability, then that makes it a little easier for us because we can just focus on decompressing the spinal cord. We also want to know, has a patient had prior surgery? And that can play a big factor in choosing what the most appropriate surgical approach may be. For years, and currently this is still true, the anterior surgical approaches tend to be our workhorse, and we have a lot of experience this here in Cleveland at Case Western Reserve, owing to the experience of Dr. Bowman and Dr. Emery, who really made this something that we do frequently and commonly. The advantage of the anterior approach is it's something we're all familiar with. Technically, it's relatively easy, and it allows for direct decompression of the spinal cord, removing directly the pathology. And it allows for stability with structural grafts and plates. The downside is from the approach can be associated with pathology related to the soft tissue, with swallowing difficulties from esophageal retraction, or the potential for vocal cord injuries or change in phonation or swallowing. That can be limited for the most part with judicious retraction of the soft tissue and good surgical technique. So this would be kind of the classic anterior approach for someone with multi-level spinal cord compression. You know, this is an older slide because what we're employing here is our structural graft is a fibular autograft, whereas in this day and age, most of the time we use structural allograft bone blocks. So here's a representative case of a patient in their early 50s, and he's still working, but he's in some trouble because over the last year or so, he's had gradual increased difficulty with ambulation. He's still working. He's not having a lot of pain. his kind of clue that there was an issue was he was having a lot of numbness in his arms and hands, and gradually he developed some gait abnormality. And if you look at his MRI, he's got quite severe cord compression and even some signal change on this T2 weighted image, which emphasizes the degree and the prolonged nature of his cord compression. So he is definitely a surgical candidate, and he could be effectively managed with an anterior approach that directly decompresses his spinal cord, and included a corpectomy at C5 and a partial corpectomy at C6, interbody fusions in an anterior plate. We do use posterior approaches as well, similar to the lumbar approaches that we use for lumbar stenosis. This generally is a indirect decompression, where most of the pathology is anterior. The posterior approach allows for expansion of the spinal canal and indirectly decompressing the spinal cord. Laminectomy alone, while it's used commonly in lumbar spine, really is only historical interest in the cervical spine because of the preponderance of developing instability. So a laminectomy alone in the cervical spine really is contraindicated. More commonly, what we would do is a laminectomy along with a fusion, or another really appealing option from a posterior approach is laminoplasty, where the spinal column, the back of the spinal column, the lamina, are lifted, not removed, allowing for expansion of the canal and spinal cord decompression. The advantages of the posterior approach are that, again, technically it's not terribly difficult, and it avoids the severe anterior morbidity. If a patient has had multiple prior anterior surgeries, they likely are better suited with a posterior approach. It can be challenging, though, if the bone quality is poor, if a patient is osteoporotic, and you may not have the ability to correct a deformity as much as you do with the anterior approach and structural grafting. And certainly there are the opportunities where we'll do both an anterior and posterior approach. So the posterior approach with laminectomy fusion would be this scenario where the canal is decompressed and then stability is added with placement of small screws in the lateral mass. It's not a large bone surface, but you can actually get fairly good fixation with multiple screws in the lateral masses. But this option is one that we've started to do in this country over the last decade or so. It was really popularized by the Japanese, who are wonderful cervical spine surgeons. They have a lot of ossification of the posterior longitudinal ligament in their population, and that's a procedure that really demands a posterior approach. So laminoplasty is done, again, with the patient prone, a posterior approach, and rather than removing the lamina, they are lifted. So on one side of your surgical approach, a hinge is made by creating a trough, and then on the opposite side, that hinge is completed and the bone is expanded and lifted as a unit, and you really can get excellent expansion of the spinal canal and indirect spinal cord compression. And so an ideal candidate for this type of patient is this younger adult. This man is a personal trainer in his late 30s, and you would think, why is he myelopathic? It's not necessarily because of advanced degenerative changes. What he has is he has severe congenital cervical stenosis. So you look at his plain film, he's got perfectly preserved cervical lordosis without a lot of degenerative disease, but his MRI shows disc bulging at multiple levels, along with the congenital narrowing resulting in severe cord compression. And so he's an ideal candidate for this procedure, laminoplasty, which allows for expansion of the canal at multiple levels, does not subject him to a fusion at a young age, preserves motion, and predictably, he did extremely well with this, with resolution of his symptoms. Kind of unbeknownst to me, he went back to martial arts fighting, which I did not support necessarily, but as you know, patients do what they want to do. Well, what about the natural history of myelopathy? It's been studied for decades. Unfortunately, myelopathy is not a condition that necessarily lends itself well to a prospective randomized study because of the nature of the disease being very progressive at times and leading to real severe issues. Probably not appropriate to do a prospective study similar to what has been done for lumbar stenosis. But nonetheless, we do know some generalities of the nature of myelopathy, and we know that it can be insidious in onset. It may go undiagnosed early on, again, owing to the lack of pain that patients may have. There may be long periods of quiescence, and rapid deterioration, suddenly getting worse, is relatively uncommon. And as a result, patients can present initially with quite advanced degrees of myelopathy. And we know as such that generally myelopathy is best treated surgically. We're beginning to get some pretty good quality evidence, and as a result, some of the spine societies, like the North American Spine Society, are beginning to make position statements on the best recommended approaches and appropriate use criteria. And this is one that came out 3 years ago from AO Spine, looking at patients with advanced myelopathy, either severe or moderate myelopathy. And the review of the literature and the agreement of the experts in the field led to quality of evidence that was really pretty good, and the strength of the recommendation was good, and the result was that most patients with advanced myelopathy should be treated surgically. And equally important conclusion was that the majority of these patients will improve. It had kind of been a long-held tenet of myelopathy that the reason we do surgery is to prevent people from getting worse, to prevent neurologic decline. And, if they had improvement, that was just an added benefit or dividend. Clearly, though, patients do improve even with advanced myelopathy. So it underscores the fact that myelopathy generally is a surgically treatable disease. However, some patients will present with mild myelopathy. Their features are not as severe. Perhaps they have symptoms more radicular in nature and some mild myelopathic features that are picked up. Then the dilemma becomes should they be managed like patients with advanced myelopathy, or can you watch them and treat them conservatively? And again, AO Spine came out with a position statement. In this scenario, however, with mild myelopathy, the quality of evidence was not as good. And as a result, the strength of recommendation was not as good. And I think as spine surgeons, this is all something that we know. We're not really certain what the best approach is. And you really, as a result, need to spend a lot of time with the patients and their families on how to approach this. And so patients with mild myelopathy, if you choose not to manage them surgically, you need to closely observe them and educate them. But it's quite controversial. Some spine surgeons will look at an MRI and say, if that patient has any myelopathic features in the setting of cord compression, you're doing them a disservice by not operating on them. I think regardless of the approach that you take, you need to educate the patients closely and carefully on this. The extension of this is individuals that have spinal cord compression but have no features of myelopathy, that are asymptomatic, that have no objective or subjective features of myelopathy, yet have been identified as having spinal cord compression. And this is a real challenge because we know, again, that the presence of spinal cord compression can progress over time, either acutely or chronically. And so incidentally found spinal cord compression is a real issue. And I must say that it's becoming more of an issue. And I think the reasons why are we're seeing our patients age and stay active, and the access to advanced imaging is becoming more readily available. So I think I've certainly seen this over the course of my career, that we're seeing more patients with cord compression without symptoms. And, we're asking ourselves, what's the best treatment option for these patients? And basically, there are two options for these individuals. One is you can offer them prophylactic surgery. They have no symptoms, they have no myelopathic features, but they have significant cord compression that would at least make surgery relevant for discussion. Or you can take the sort of watch and wait approach, where you're going to observe the patient, educate them about the nature of what they have going on in their cervical spine, educate them on things to avoid, and then follow them carefully to make certain that they do not develop myelopathic features at some point in the future. Again, a position statement has been reached on this, and this came again from the AO North American Spine Group. And I think these were really pretty judicious and relevant conclusions. And it underscores the limited nature of what we know about this, but I think there is some suggestion to suggest that if a patient does not have myelopathic features, that we don't have a great foundation to say they absolutely need surgery, because we don't have great information that says who is going to progress and when they will progress. So I think a judicious recommendation, and generally my approach is, if a patient has a normal neurologic exam and no myelopathic features, I think it is perfectly reasonable to educate that patient, treat them non-surgically, but really insist that they have close clinical follow-up. And so I think that's kind of the conclusion, that for patients with spinal cord compression, the decision for surgery should really be anchored in making absolutely certain that they don't have myelopathic features sort of below the surface that are not apparent. And if you choose not to offer them surgery, follow them carefully over time. And so for this individual, this was several years ago, but as kind of the quintessential patient, this is a patient in his early 60s. He's an attorney, of course, and he had developed some neck pain after doing some yard work. He saw his primary care physician, who got an x-ray and saw some significant spondylitic changes on plain film, became concerned about them and ordered an MRI and sent him for a spine consultation. By the time the patient reached me 2 or 3 weeks later, his symptoms of axial neck pain had resolved. And he had no symptoms, no radicular symptoms. He definitely didn't have any myelopathic features, but he had an MRI that revealed multi-level spondylosis and relatively significant spinal cord compression. So we were talking at lunch about certain clinical scenarios which are clinic killers, and this is a clinic killer. You can spend an hour with patients on this and really need the importance of educating them and giving them what would be an appropriate framework of a treatment algorithm. And I think in my hands, if the patient has no features of myelopathy, you can take the watch and wait approach with careful patient education and close surveillance. And then finally, I'll close with this, which is an area of interest of mine, which 2 of our research fellows did a nice project on over the last 6 months or so, and just actually yesterday presented at the North American Spine Society's national meeting, looking at the outcomes of patients with the most severe clinical presentations of myelopathy, patients that were non-ambulatory, patients that had such severe cord compression of long-standing nature that they presented unable to ambulate. And obviously the concern would be, are these patients, should they undergo surgery? Can we offer any predictability that surgery would help them? Oftentimes, these are patients that are older, they have significant comorbidities. So surgery is not a slam dunk, and the potential of morbidity associated with surgery might be relatively high. And if you can't offer any predictability that surgery will help them, maybe you ought not to offer them a surgery. And so what we did was we looked back over a 10-year period here at CASE and identified nearly 50 patients that fit this presentation parameter, that they were non-ambulatory at the time of presentation. And they were classified as NURIC 4 or 5. And NURIC is a classification system that primarily is based on a patient's ability to walk and to work. And NURIC 4 and NURIC 5 are defined as either only able to stand or unable to even stand. And what we found was that the vast majority of patients that did have surgery regained the ability to walk, particularly the NURIC 4s. And so 44 of the 48 patients, over 90%, regained the ability to ambulate. We also evaluated their clinical symptomatology with the JOA score, the Japanese Orthopedic Association score, which is an objective way of looking at function and symptomatology related to cervical spine disease, and found that the majority of patients had substantial improvement in their postoperative JOA scores of up to 3 points, which is on a 17-point scale. So that was a significant finding. And so the conclusions were that even these patients with long-standing myelopathy that had progressed to the point where they were non-ambulatory would benefit from surgery, and the complication rates were relatively small and no different than in a cohort of ambulatory patients. So it underscored our feeling that, yes, we should offer these patients surgery in hopes of improving their ability to stand and ambulate. And so an example of this was this 82-year-old man that I took care of probably 3 or 4 years ago. And he presented to the office unable to ambulate and had not been able to ambulate for at least a year. He was having some degree of neck pain, but not a lot of pain, not a lot of radicular pain. And like oftentimes in the case of patients that present like this, he didn't have much social support. He was living by himself. He had someone come in to assist him periodically, but nobody would really identify the fact that he had been declining over time to the point where he couldn't walk. And so then the decision is should this man who has multi-level spondylosis and will need a relatively big operation, he's deconditioned, he's an octogenarian, should you subject him to a major surgery? And can you offer any predictability that it will help him? And so again, my approach generally is, yes, I will offer these individuals surgery if they're a medically suitable candidate. He was a good candidate for laminoplasty because his lordosis and his alignment was preserved. And so laminoplasty is not nearly as big as operation as a multi-level anterior approach or even a posterior fusion. So we could do this surgery relatively quickly in 2.5 hours without a lot of blood loss. So it was a good operation for him, and he did improve. Within 6 months, a lot of his paresthesias had improved, but more importantly, he'd regained the ability to ambulate with a walker. So really, in summary about myelopathy, we know that it is a clinical diagnosis. Certainly, we rely a lot of our planning on advanced imaging, but it is just essential to have a high degree of suspicion when patients present with weakness or coordination issues or gait abnormality, even if they're mild. And an MRI or advanced imaging is really essential if you have any clinical suspicion. Patients may present with advanced conditions for the first time. And, of interest, they may present to different practitioners. They may present to their primary care physician or to physical medicine specialists or surgeons or general orthopedist or a total joint specialist. And it's really critically important to have a high degree of suspicion if a patient presents to you with gait abnormality and objective features of myelopathy. Generally, surgical management is the treatment of choice, and it is very effective in most cases. And that's true for even patients with the most advanced myelopathy. Milder cases can be watched, as can cases of asymptomatic cord compression, but it's essential to educate the patients and have close surveillance. So I'll stop there. And again, thank you to Dr. Marsolais for, his really decades of service to the spine community and the rehab community, and to Case here. I think for a picture of resilience, you have to look no further than Dr. Marsolais. So thank you.